Welcome back, guys. This is going to be the part two to our preview of the lecture. We'll cover roughly around 30 slides again. I believe we left off discussing the pituitary gland. And the pituitary gland, again, if you guys can remember from the previous lecture preview, the pituitary gland is going to be just inferior to the hypothalamus. As we previously discussed, the hypothalamus is going to be the control center of the pituitary gland and kind of regulate it, as you can see on this previous slide that we have back here, talking about hypothalamic control. Hypothalamus is going to be responsive to all these different stimuli that comes in, autonomic inputs, osmolarity, stress being a big one. Stress can actually feed into the hypothalamus, causing the release of something called corticotropin releasing hormone, or CRH, and that will cause the release of ACTH. As we discussed here about the hypothalamus's relationship to the pituitary gland, it's just a little bit superior to the pituitary. Pituitary sitting in here in something called the sella turcica, which is a portion of the bone where the pituitary sits. And again, we have this hypothalamic pituitary axis here that we will begin discussing. So again, the pituitary gland is connected to the hypothalamus through something called the infundibulum, which is the pituitary stalk. Blood supply coming from the heart through the hypothalamus and to the pituitary gland and eventually to the circulatory system is how these hormones are distributed. This is called the hypophyseal portal system, and I'll show you that on this next slide. So this is going to be the hypophyseal portal system. You're going to have the superior hypophyseal artery here, very close in relationship to the infundibulum, again being the stalk that connects this pituitary gland to this hypothalamus. I know these are a lot of words and this is a lot of stuff to try to take in. I just want you to know there's a series of blood vessels that's responsible for allowing these hormones to be distributed to where they're supposed to go, right to their target organs. Here's a check on learning. What circulation pathway do hypothalamic hormones take? What advantage does this provide? So this is a hard question. So they diffuse into the primary plexus of the hypophyseal portal system. Where's the primary plexus located? Well, this is the primary plexus, right? This is going to be the major capillary network, which is going to carry these hormones to their respective locations. Then they travel through something called the portal veins into the secondary plexus, where they can act immediately. So you've got a primary plexus here that travels. It goes through something called the portal vein into something called the secondary plexus. And the secondary plexus is going to be located right here. What circulation pathway do anterior pituitary hormones take? They diffuse into the secondary plexus capillaries, which drain into the anterior hypophyseal and then into general circulation. So, anterior pituitary hormones diffuse directly into the secondary plexus. That makes sense. Look at exactly where their location is at. They're exactly located very close to the hypophyseal portal system, as well as the secondary plexus capillaries. So they're able to go directly there, and they will then go directly into circulation. So the advantage that this provides, they can act immediately. Right? They are directly released into that portal system, that hypophyseal portal system. And after the neurons act, they're able to directly go out to the target organs. So here we're going to discuss some of the cells of the anterior pituitary. Again, if you guys remember, we have the hypothalamus. Remember, it's the control center. It controls the pituitary. We have those inputs that come into that hypothalamus. And from here, there's going to be certain cell types present within this anterior pituitary that is going to act and cause the release of different hormones. Some of these different cells, again, these are going to just be terms that you're going to have to memorize, but their names kind of make sense. Somatotropes is going to release release something called human growth hormone, or HGH. If you've ever heard of bodybuilders taking HGH, this causes the release of something called insulin-like growth factor, and it's going to cause body growth. It's going to cause muscle cell growth. Thyrotropes. Thyrotropes is going to cause the release of thyroid hormone, thyroid. Thyroid hormone is going to be responsible for metabolism. Gonadotropes, if you think of gonads, you think about the ovaries and you think about the testes. This is going to cause something called follicle stimulating hormone. Follicles are going to be present within the ovary. And luteinizing hormone. Luteinizing hormone is going to cause the release of estrogen as well as the production of androgens. We'll discuss those later on. Lactotropes. Lactotropes, think of lactation, prolactin, causing milk ejection. And then you have corticotropes. When you think about cortico, think about cortisol, the stress hormone. So adreno, meaning adrenal gland, the adrenal gland present on top of the kidney, adrenocorticotropin hormone, or ACTH. There's also a hormone called melanocyte stimulating hormone that is released as a byproduct of ACTH release as well. So again, here's the 5 that are going to be primarily present. There's a nice little table here. Again, if you remember, every hormone has a target cell, and it shows you the location of these target cells. And I encourage you to come back to this, review this. If you know this inside and out, I guarantee you that you're going to do well on the exam. We'll just go through this briefly. Again, there's 5 different types of cells. The somatotropes will come down here to growth hormone. Being the somatotropes, growth hormone is going to be present in pretty much almost every cell in the body. So people that are taking HGH, I don't know whether they realize this or not, but it's going to cause not only increased growth of the muscle. If you think about the muscle, the heart's a muscle, so this can cause the heart to enlarge, right? So this causes increased growth of metabolism and target cells, causes synthesis of somatomedin, you don't have to know that word, but stimulates growth at the epiphyseal plate. Kids who are born with a condition called, it's not necessarily dwarfism, but short stature. Kids can be born and just have something called short stature, and they can actually be prescribed growth hormone in order to grow. And as long as their epiphyseal plate is not closed, and it has to be regulated very closely by physicians. But this is just an example where we can actually use a hormone in the body and manipulate it to be advantageous for us. Adrenocorticotropin releasing hormone, or ACTH. If you think about adreno, it's going to work on the adrenal glands. Cortico, meaning cortisol, so it's going to cause the release of corticosteroids, or cortisol. Cortisol is going to be the stress hormone that we're going to discuss later on. The gonadotropes, both FSH, follicle stimulating hormone, and luteinizing hormone. FSH is going to work in the ovaries, right? And it's going to be helpful in the maturation of the follicle, causing release of estrogen later on. It's going to cause the growth of this ovarian follicle. Within the males, it's going to stimulate sperm production. So I think of S, follicle stimulating. It's going to stimulate things, right? It's going to stimulate growth of the follicle in females, which is going to be where the egg or the oocyte is present. And within males, it's going to stimulate sperm. Now, luteinizing hormone, it's the other gonadotrope. It is going to, again, work within females at the ovary, within males at the testes. Within males, it's going to stimulate androgen synthesis, or the production of testosterone. Within females, it's going to be responsible for something called the LH surge. That'll be a very high yield point that we'll need to take note of later on. And it's going to, the LH surge is going to be responsible for estrogen production. Thyroid stimulating hormone, again, this is a very big topic. Thyroid stimulating hormone is going to work where? The thyroid gland, remember, that's present within the neck, around the area of the Adam's apple within males, around the level of the hyoid bone, and within that location. It's going to stimulate thyroid hormone synthesis. Prolactin, if you think about lactation, think about milk coming out of the breast. This is going to within within females, going to work on the mammary glands, which are going to be actually present within the breast tissue, stimulating milk production. The males, uh, not necessarily a big role. It does have some effect on the gonads, but for our purposes, we won't necessarily dive into that. Melanocyte stimulating hormone works on the melanocytes. Melanocytes are going to be present within the skin. This is actually what is going to be responsible for the synthesis of something called melanin, which is, depending on how light or dark your skin color is, will depend on how much melanin you produce. So, as you can see in the lecture, I don't have very much melanin as I'm very fair complected. So here's just a statement. All of these hormones have releasing hormones, right, from the hypothalamus, or an inhibiting hormone, something that blocks them coming from the hypothalamus. So as I previously discussed with thyroid hormone in the earlier portion of the lecture, maybe even in this lecture, thyroid stimulating hormone, while this is coming from the pituitary gland, you have something from the hypothalamus controlling it called thyrotropin releasing hormone, or TRH. So TRH causes the release of TSH. This same thing for ACTH, adrenocorticotropin releasing hormone. CRH, or corticotropin releasing hormone, CRH, causes the release of ACTH from the pituitary gland, which will then in effect go to the adrenal cortex. Just a little side note, I want you guys to study again. These are all coming from the pituitary, but there are releasing hormones that come from the hypothalamus, which causes the release of these stimulating hormones from the pituitary to then go onto their target location. Again, the hypothalamus controls everything, causes the pituitary gland to release hormones, which will then go to their target destination in order to produce the hormone. We'll get into each of the hormones specifically here. So this is a picture of a man with something called gigantism. And again, this comes from a hormone called growth hormone. Most likely this man here had a tumor present within the pituitary gland. And that makes sense because the pituitary gland, remember, they have those cells called the somatotropes, which are responsible for releasing growth hormone. And if you can remember from our table, growth hormone is responsible for increasing growth and metabolism in every target cell. So this man had a tumor in his pituitary gland called a pituitary adenoma. It's just a $3 word for tumor, benign tumor, doesn't metastasize, stays local, and within the pituitary gland causes the release of something called growth hormone. So what I want you to know is I want you to know what growth hormone does. Growth hormone is responsible for stimulating body cells to grow and divide, right? It's responsible for stimulating body cells to grow and divide. Growth hormone as a byproduct, so when growth hormone is secreted and it goes to its target destination, it also causes the release of something called insulin-like growth factor, and that's a mediator protein that kind of helps growth hormone function. And again, this is just another point to show you that growth hormone, while it's released from the pituitary, is controlled by the hypothalamus. And that comes from growth hormone, releasing hormone. It makes sense, right? Its name tells you what it does. Growth hormone, releasing hormone from the hypothalamus causes growth hormone secretion within the pituitary. Growth hormone then goes to its target destination, which we've said within our table, it's pretty much every cell, and causes them to grow and divide. Here's a picture of growth hormone pathway. Again, this is just something that will show you the pituitary gland here is causing growth hormone. Growth hormone is then going to the liver and is producing something called insulin-like growth factor, or IGF-1. And it also goes to different areas here, causing the muscle to grow. It goes within fat, and it causes fat to break down. It's responsible for all these things here. Amino acid transport. If you guys remember that the amino acids are what? right? They're the building blocks of protein, so that makes sense. They're the building blocks of protein. They're going to increase protein synthesis. And remember that in order for things to grow and have energy, they're going to need glucose, so glucose transport as well. Again, this is just another picture that I was previously describing to you. This man right here has gigantism. This is this area where this big mass is. With inside it is going to be an area called the sella, Sella, turcica, Turcica, sella turcica. The sella turcica is going to be where the pituitary gland is normally located. This mass right here is a very large pituitary adenoma, and it's causing excess, meaning too much production of that growth hormone. Therefore, this is why this man got extremely large. Um, Here is a scan. This looks like a lateral X-ray, a lateral image where you can see the mass actually visible right here. After this, so we are going to now talk about the lactotrophs. You can remember the lact meaning milk ejection or lactation, and we're going to talk about the hormone prolactin. So prolactin, I want you to know, it's responsible for breast development, right? And milk production. Milk production is going to be primarily what I want you to focus on, milk production. So when women become pregnant, the body is going to recognize that, and the anterior pituitary is going to secrete something called prolactin, right? Again, a normal function of prolactin in males has not really been established, but prolactin releases inhibiting hormones from the hypothalamus, which restrains secretion of prolactin. That's actually called dopamine. Dopamine is normally going to inhibit prolactin formation. Here we have a question that I'd like for you guys to try. After childbirth, the hormone prolactin is secreted in the mother by, is it the hypothalamus, the anterior lobe of the pituitary, the posterior lobe of the pituitary, or is it the intermediate gland? Give you guys just a few seconds. You can see here on the slide it says anterior pituitary, right? The anterior lobe of the pituitary. If you guys remember, the hypothalamus is responsible for controlling the anterior lobe of the pituitary, so that the actual ejection of prolactin comes from the anterior lobe of the pituitary. From there, prolactin will then go to the breast and will cause the ejection of milk. Do you guys remember the two hormones that are present in the posterior lobe we discussed previously in the last lecture? There's only two. It's oxytocin. Oxytocin, that is responsible for milk ejection as well as uterine contraction during childbirth. And ADH, right? Oxytocin and ADH. ADH is going to be responsible for controlling the amount of water that goes into the renal tubule or your kidneys, which is responsible for peeing. So whenever we have production of ADH, we try to conserve water and we try to conserve body volume. We'll move on down, as you can see here in this picture, very good picture. We're going to begin discussing the thyroid stimulating hormone. Here we have the hypothalamus, and again, we said that there's releasing hormones always controlling the pituitary gland. So in the case of thyroid stimulating hormone, we have something called TRH, or thyrotropin releasing hormone, TRH, then goes down to the pituitary gland and causes the release of thyroid stimulating hormone, or TSH. And from there, the thyroid gland is then going to produce something called T3 and T4. These are actually the active components of thyroid hormone, whereas T4 is going to be the active portion. We'll discuss this later on. But thyroid stimulating hormone is going to control the secretion of hormones from the thyroid gland. The hypothalamus, by secreting thyrotropin releasing hormone, regulates TSH secretion. What does thyroid hormone do? Thyroid hormone is going to be responsible responsible for increasing metabolism. That's the point I want you to know. It increases metabolism. It's also responsible for growth and development. There is a condition in which children are born with too little thyroid hormone. That's called hypothyroidism, right? Hypo meaning below, too little thyroid. So guess what they don't do? They do not grow and develop at a normal rate as a normal child would. It was previously called cretinism, and I'll show you guys why. Um, Terms kind of been frowned upon now. So cretinism, and this is why children were born with too little thyroid, and they didn't develop normally. Here is a congenital iodine deficiency syndrome. And remember, I previously said that during the biosynthesis stage of forming hormones, especially thyroid hormone, we had to have iodine present. Well, mothers who had a deficiency in iodine, they couldn't produce enough thyroid hormone for the baby. Therefore, babies would be born with hypothyroidism. This is something that we catch early on now, that foods are mostly iodized now, which kind of prevents this. But again, this is a condition just to be aware of. It just kind of shows you the effects that thyroid hormone has. Back to our lecture. So again, increasing metabolism as well as growth and development. That's important. Once we have enough T3 and T4, this is a very good slide that will show you negative feedback. So whenever we produce T3 and T4, we're going to shut down the production of thyroid. We've got enough, right? So thyroid hormone T3 and T4 actually go back up to the hypothalamus and say, hey, look, we've got enough. You don't have to produce. So it inhibits TRH production. Basically says stop making it. There's a condition called hyperthyroidism in which this whole system's broken, right? There is an autoantibody against the TSH receptor, which prevents it from working effectively. So the TSH is not stimulated, but you're continuously producing these thyroid hormones. So T3 and T4 is continuously getting produced in excess, and there is no feedback. The negative feedback system shut off. That's another point we'll discuss later on. ACTH, or adrenocorticotropin releasing hormone, ACTH, is going to be responsible for the secretion of hormones from the adrenal cortex. The biggest one that I want you guys to know is going to be cortisol, right? Cortisol produced from the adrenal glands. Cortisol is going to be the fight or flight hormone. It's going to be responsible for increasing stress. It's going to be responsible for breaking down different, whether it be fat or responsible for breaking down protein synthesis and proteins and producing sugar within the body. Here is another example of the way the hypothalamus likes to work. You have CRH, which is produced within the hypothalamus, corticotropin releasing hormone, coming in here to the anterior pituitary, producing ACTH. If something were to happen and let's say ACTH was not working effectively, then you would have excess CRH production, right? Because again, we couldn't produce cortisol down here, the corticosteroid, which therefore the corticosteroid could not negatively feed back and inhibit CRH production. Same thing here. If you had, there's a condition called Addison's disease. Addison's disease is going to be basically an autoimmune disease where the body attacks the adrenal gland. The body destroys this adrenal gland, so guess what can't form? Cortisol, corticosteroid. So because this does not get produced, there is no negative feedback to shut off CRH production. So CRH is considered high, to be very high within the body. Because CRH is high within the body, what's it going to do? It's going to cause ACTH to be very high. But again, cortisol is not going to be able to be produced. So what do? How do we fix this disease? Well, you can't really fix the disease, but what we can do is we can kind of treat that. And we give those patients something called hydrocortisone or cortisol. We give them an artificial corticosteroid. What does that do? Because you are giving them the artificial corticosteroid, that's going to go back up here to CRH and say, hey, we've got enough in the body, so why don't you tone it down? So, where these numbers were previously very high with CRH, it's going to kind of lower those and shut them down. What does that do in turn? That lowers ACTH levels as well. Moving on to the posterior pituitary, there is going to be primarily the production of two different hormones, ADH and oxytocin, like we previously just said. Here's a major note. The posterior pituitary does not synthesize these hormones, right? But it does store and release them. So ADH and oxytocin are both going to be stored and released from the posterior pituitary. There's two different areas within the posterior pituitary, the pars nervosa, as well as the infundibulum. The infundibulum, again, that's the major point that I want you to know. It's just going to be the connection point, that stalk that exists between the hypothalamus and the pituitary. Again, you can scroll back up to the previous pictures and kind of see that depicted. What is important is knowing the function of both ADH and oxytocin. Oxytocin is going to be synthesized from the paraventricular nuclei. You don't have to know that exactly for us, but oxytocin is responsible for contraction of the uterus. Whenever women become pregnant and they begin to undergo childbirth, the baby is going to press on the uterus, causing release of oxytocin. That is going to stimulate uterine contraction or contraction through the birth canal, which is going to help the baby be born. ADH, anti-diuretic. What does diuresis mean? Pee. So you have an anti-pee. We have an anti-pee hormone. How do we pee? Well, water is present, or whatever concentration is present within the kidney that causes us to pee. Because we have an anti-diuretic hormone, instead of the water going into the renal tract, it's going to get pulled back out to the blood, and that's going to be responsible for restoration of volume. Here are some other pictures: follicle-stimulating hormone and luteinizing hormone, FSH and LH. These are going to be hormones that affect the gonads. Here's a good picture. Here you can see the pituitary gland releasing FSH and LH. This is going to then come down here to the sperm. This is going to be the epididymis on this outer portion here. But before it gets there, there's the area called the vas deferens and the ductus deferens, which is going to be the area where sperm maturation is going to occur. LH is going to come down and cause the Leydig cells, Leydig cells, to produce testosterone and produce sperm. Because LH and FSH are high, testosterone is able to be produced. Thyroid gland, we're going to get into the cells here. The thyroid gland is going to be a butterfly-shaped gland located in the inferior portion of the neck, the larynx. It has a right and left lobe on both sides of the trachea. Go up to your neck and feel where your trachea is, where the area is coming down. You can't really exactly feel the trachea, but you can kind of feel of your neck area. On the right and left side is going to be where your thyroid gland is. Within the thyroid gland itself, it has follicles. These follicular cells are going to be responsible for the release of thyroid hormone. Para meaning beside, parafollicular cells. The parafollicular cells, or the cells beside the follicular cells, release something called calcitonin, and it tones down the calcium present within the blood. And it does that by acting on bone. Again, the follicular cells release thyroid hormone. T4 is a prohormone that is converted to T3 by an enzyme called deiodinase. T3 is going to be the active hormone that controls the rate of metabolic processes. So again, just to kind of go over the thyroid gland, it's going to be in the inferior portion of the neck, has a right and left lobe. Those lobes are contain follicular cells where thyroid hormone T4 and T3 are contained. T4 is going to be the prohormone. Pro means that it has to be activated in order to become active, and it does so by an enzyme called deiodinase. T3 is going to be the active portion, and it's going to control the rate of metabolic processes within the body. Para means beside the follicular cells. It contains calcitonin. Calcitonin tones down the calcium within the blood. Moving on to the posterior pituitary. The posterior pituitary is going to, again, like we previously just said, it's going to be responsible for the control of, it's going to store and release two hormones, oxytocin and ADH. As you can see here, oxytocin causes the mammary glands to release milk, as well as causing uterine muscles to contract. ADH is going to work on the kidneys, present at the kidney tubules. This inhibits diuresis or urine production, and it also increases blood pressure. So because you inhibit diuresis, you prevent water going into the kidney. You're going to bring that water back into the blood, which is also going to increase the blood pressure. Again, just kind of hitting on thyroid hormone. Again, this is a previous slide that we had discussed about TRH coming from the hypothalamus, causing the release of TSH, from there causing the release of T3 and T4 from the follicles. Here's the main function of T3 and T4. T3, again, being the active portion, causing an increased rate of metabolism, increasing protein synthesis, stimulating the lipid breakdown, and it's also needed for normal growth and development. Again, remember the cretinism child who didn't have enough thyroid hormone. Because he didn't have enough thyroid hormone, he couldn't grow and develop at a normal rate as other kids. Here's just a picture kind of depicting what I said about the thyroid gland. It's here is your larynx or your voice box. If you feel right here, this within males, this will be your Adam's apple. Inferior to that would be the thyroid gland. So this is the left lateral lobe. This is the right lateral lobe. If you could get at a more microscopic level and actually see inside of this thyroid, you would see the follicular cells, which I'll show you on the next slide. These are the thyroid follicles. And again, these follicles are full of T4 and T3. Remember, T3 is the active portion. T4 must be first converted by an enzyme called deiodinase into T3 in order to become active. Once it becomes active, it goes out to its different target tissue, and from there, it's going to increase metabolism by protein breakdown, lipid breakdown, and things like that. Again, here are your follicular cells, and here are going to be your parafollicular cells. Do you guys remember the hormone that is present within the parafollicular cells? That would be calcitonin. Calcitonin, do you guys remember its function? Okay, calcitonin is meant to tone down the calcium present within the blood, right? It does that by acting on bone. Let's do a check on learning. Describe the differences in hormone release and gland size for someone who has had their thyroid removed. What hormones are increased? What happens to the receptors? Is hormone production decreased? If so, where and why? So, in someone who has hypothyroidism, okay, someone whose thyroid isn't necessarily working. Let's go back up to this picture. Let's say their thyroid's not working. They have Hashimoto's disease, which destroys the thyroid gland. There is a condition in which because T3 and T4 is not made, would you expect TRH to be high or low? Well, it'd be high, right? Because there's no negative feedback. There's nothing coming back telling it to shut down. Because TRH is high, what is TSH? Well, it has to be high as well. Because TSH is high, it's continually going down to this thyroid gland and stimulating it and trying to get it to grow. Because it's trying to get it to produce these cells, it's continuously stimulating the receptor, which is going to cause an increase in growth of the thyroid gland itself. There's also a condition. There's a condition called Hashimoto's in which there is complete destruction of the thyroid follicles themselves. Because the thyroid follicles are destroyed, T3 and T4 is decreased, right? Which causes excess TSH and TRH production to come down. These patients get something called a goiter, in which their thyroid gland it actually grows and swells, but the thyroid follicles themselves are completely destroyed. So what happens to the receptors? Well, if a patient had their thyroid gland removed, They would have no receptors, would they? Because remember, where are the TSH receptors? They're present within the thyroid gland. So is hormone production decreased when someone has a thyroidectomy? Let's say they have thyroid cancer and they had their thyroid removed. Are they still able to produce that hormone? No, they're not, right? But what is TSH and TRH? Because they can't produce T3 and T4, what would you guys expect TRH and TSH to be? Well, it would be increased because, again, there is no negative feedback, right? There is no negative feedback. The hormones that would be increased are, again, thyroid stimulating hormone and thyrotropin releasing hormone. Describe the effects of a hypothylectomy would have on an individual, assuming they live through it, with respect to hormone release and body function / homeostasis. So a hypothylectomy, this doesn't exist. But if the hypothalamus was removed, what would happen to thyroid hormone production? It would be decreased, right? Because again, remember, the hypothalamus is responsible for controlling the pituitary gland. If you guys remember previously, TRH or thyrotropin releasing hormone, right? It causes the pituitary gland to release what? TSH, right? Thyroid stimulating hormone. And where does TSH go? To the thyroid gland to produce T3 and T4. Good job. Yes, absolutely. Again, this is just kind of hitting back on what I previously discussed. I think it's good to go over things multiple times to kind of just drive this into your guys' head. Calcitonin is produced from the meaning beside, follicular cells. Beside of the follicles, parafollicular cells. What do the follicles contain? T3 and T4, absolutely. Parafollicular cells contain calcitonin. Calcitonin goes into the blood and it lowers blood calcium levels. So if somebody has something called hypercalcemia, in which the blood calcium is too high, that triggers calcitonin release from the parafollicular cells, and it goes and it lowers blood calcium. It also lowers blood phosphate ion concentration, but for our purposes, I want you to know that it primarily lowers blood calcium. And it prevents prolonged elevation of calcium after meals. This is just an example, an example of what I previously discussed with you. Calcitonin released from the parafollicular cells of the thyroid. It goes and it lowers calcium levels within the blood. It also inhibits calcium absorption by the intestines, and that makes sense. If we're trying to lower calcium level within the blood, we don't want to absorb any calcium as well. And it inhibits calcium reabsorption in the kidneys, promotes deposition of calcium into the bone. So in order to calcitonin is actually going to build strong bone by taking the calcium within the blood and depositing it within the bone. Here is the parathyroid gland. So again, going back, we've got the thyroid gland, and within the thyroid gland contains the follicles as well as the parafollicular cells. So we have follicular cells, which contains T3 and T4. Then we have the parafollicular cells, which contains what? Calcitonin. Absolutely. Beside the thyroid, we have something called the parathyroid. So this is beside the thyroid gland. Parathyroid gland is going to be located exactly like the name says, near the thyroid, right? It's located posterior to the thyroid. It has two lobes, just like the thyroid gland. And a lot of times after patients have a thyroidectomy, the parathyroid glands are removed as well because they're just so close in proximity to each other. There are two different cell types which are predominantly make up the parathyroid gland. These are the chief cells, which are the cells that I think are the most important because they actually are responsible for the production of parathyroid hormone, right? So what does parathyroid hormone do? Well, it's going to regulate calcium levels, much like calcitonin. And parathyroid hormone and calcitonin kind of oppose each other. So when blood calcium levels are low, parathyroid hormone is activated, right? So again, down here in bold, I have stimulated by low blood calcium levels. So if somebody has hypocalcemia or low blood calcium, guess what's going to happen? The parathyroid glands are going to become activated, and they're going to act on the kidneys to produce calcitrol, which is going to be the active form of vitamin D. And they're going to regulate calcium by pulling it off of the bone, right? They're going to activate the osteoclasts, which are going to be responsible again for bone resorption. If you guys can remember that from Anatomy and Physiology 1. So the parathyroid hormone, again, just to reiterate, this is behind the thyroid gland or near the thyroid gland. It has two lobes. The primary cells that are responsible for the release of PTH or parathyroid hormone are the chief cells. The parathyroid gland is stimulated by low blood calcium levels, and it works to increase those calcium levels. How does it do that? It does that simply by activating the osteoclasts present within the bone in order for bone resorption to occur. So it brings up the calcium levels. It also works on the kidneys to form vitamin D through the production of calcitrol. This is a picture just depicting where the parathyroid glands are located. Again, this is going to be posterior. This deep purple is just showing you that it's deep to the parathyroid glands. You guys remember what the term deep means? Deep means not superficial. It means actually deeper, not near the surface, actually deeper. So it's deep to the thyroid. Again, this is going to be at the level of the trachea, coming down here posterior, branching out. And here is the cartilage. This is just another picture here showing you how parathyroid hormone works. You have an increase in blood calcium level. This causes the increased secretion of calcitonin, right? Because calcitonin tones down the calcium in the blood. If you have a decrease in blood calcium, what does that do? That's going to increase parathyroid hormone. If you guys remember those terms that we've previously discussed, antagonistic effects. So I previously used the example of insulin and glucagon, how they oppose each other. So PTH and calcitonin does the same thing. Wrapping up, guys, I know this has been a long lecture. But let's talk about the adrenal glands very quickly. So the adrenal glands are going to be present at the superior portion of the kidney. They're going to be responsible for the secretion of three different hormones. That's going to be aldosterone, cortisol, and the androgens. Again, important points to know: they're located at the top of the kidney, superior aspect of the kidneys. They have an outer covering called a capsule. And they're made up of two different areas. So we have an adrenal cortex and adrenal medulla. The cortex is the outer portion, right? This is the outer covering, and the medulla is actually the inner surface. Within the adrenal cortex, there are three different layers: the zona glomerulosa, fasciculata, and reticularis. There is a mnemonic that I want you guys to know. Go, fetch, rex, salt, sugar, sex. What does that mean? So the zona glomerulosa, which is go, this is going to produce a salt, also called a mineral corticoid. That mineral corticoid is going to be aldosterone. Zona fasciculata, that is the F in the fetch mnemonic, go fetch, fasciculata. Salt, sugar, this is going to be the glucocorticoid, right? Cortisol produces sugars, as we previously discussed. And then what is rex in the mnemonic? Zona reticularis. Salt, sugar, sex hormones, androgens. Okay, I'm going to go over that again. The adrenal cortex is going to be the outer portion, right? This is going to be the outer portion of the adrenal glands. It's going to have three different layers: the glomerulosa, the fasciculata, the reticularis. It's going to produce mineral corticoids, glucocorticoids, and androgens. There's a mnemonic that's very helpful. Go, fetch, rex, salt, meaning aldosterone, the mineral corticoid, sugar, meaning glucocorticoid, and sex, meaning the sex steroids. Salt, sugar, sex, go fetch, rex. The adrenal medulla is much simpler than the adrenal cortex. It's going to contain an area called the chromaffin cells, and they're going to produce epinephrine and norepinephrine. Epinephrine, these are going to be your catecholamines, which are going to be responsible for fight or flight. It's going to also cause things like bronchodilation present within the lungs. Here's an important note that I've listed down here. The adrenal cortex is stimulated by ACTH, right? ACTH, remember, comes from the pituitary gland, comes down to the adrenal cortex, and it produces all of those. It produces Um, Aldosterone, or no, I'm sorry, it does not produce aldosterone. That's a renin-angiotensin-aldosterone system. It produces glucocorticoids such as cortisol, as well as having a production of the androgens. Here is another. This is another thing. Angiotensin 2 will work by stimulating the zona glomerulosa to increase aldosterone. The adrenal medulla is stimulated by acetylcholine. Acetylcholine is going to be present, if you guys remember, from AMP1. It's going to be released from the parasympathetic tract, and it's going to cause an increase in the uh, production of these hormones as well. Here's a picture kind of depicting what I previously discussed. You've got the adrenal glands, which are going to be present on the superior poles of the kidney. Um, the outer covering here, there's a fatty layer often outside called the adrenal cortex. Present within inside is going to be the adrenal medulla. If you guys remember, the adrenal medulla is made up of the chromaffin cells, whereas the adrenal cortex is made up of the glomerulosa, fasciculata, and the reticularis. This is another picture, just kind of showing you a histological slide of the adrenal cortex. The adrenal cortex, again, having these three different layers, having the cortex, the fasciculata, and the reticularis here. The medulla is going to be the inner portion, which is going to contain those chromaffin cells. Those chromaffin cells are going to be neurological in origin, so therefore they're going to be stimulated by neuronal cells as well by acetylcholine. Again, glomerulosa, fasciculata, reticularis, this being the adrenal cortex, and here being the medulla. This is just a picture kind of depicting, again, this whole thought process and this whole mechanism behind negative feedback. Again, this is you have stress, which is going to be our input, again, our stimuli. If you guys remember the homeostatic mechanisms coming into our sensor, right? We're going to sense stress. It's going to be sent to the integrator, which is going to be our hypothalamus. The hypothalamus is then going to integrate that information and send that down to the pituitary gland, which is going to be ACTH. Production, and again, ACTH will go down to the adrenal glands. The adrenal glands will cause a production in cortisol as well as androgens. I want you guys to think what would happen if I took out your adrenal glands. We had an adrenalectomy. What would you expect ACTH to be, high or low? Well, if cortisol is taken away, if you guys remember from the previous discussion of Addison's disease, cortisol is taken away. Again, there is nothing to shut down CRH production as well as ACTH production. Because what does cortisol do, or the corticosteroids do, whenever it is produced? It comes up here to the head honchos and it says, hey boys, calm down. You guys are making too much. I've got it. Shuts them down. So if you took out the adrenal glands, again, you would have excess CRH, corticotropin releasing hormone, as well as excess ACTH. Because again, CRH drives ACTH. Again, I think I'm going to cut this lecture off here. I probably went way too over, but again, guys, these are tough concepts, and these are concepts that you're going to have to wrestle with and play with. You're going to have to understand these different mechanisms, because I promise, if you're going anywhere in healthcare from here on, these are going to continue to come up, especially if you want to go on to medical school or physical therapy school. You're going to constantly deal with these hormones, and it's important to have a good understanding. And how do you have a good understanding? Well, you have to understand things about the hypothalamus, the pituitary gland, and their effective organs. What do these hormones do? Who releases this hormone? Who causes the secretion of the pituitary gland? After the pituitary gland, where does it go? But I won't belabor any more points. I just wanted to give you guys a lecture preview. I hope you guys are finding these previews useful. Again, I'm confident if you at least watch the lecture preview, come to lecture ready to learn, there's no reason you shouldn't be able to get an A in this course. If you have any questions, please feel free to reach out to me. I hope you guys have a great rest of your day.